good morning to all, and a warm welcome to this instruction course on uveitis. We are privileged today to have very good faculty here with us for this instruction course. And today you'll be hearing them speak about practical tips in uveitis. So we have arranged it such that you can, it's not just listening to a didactic over 1.5 hours. It is going to be perfect pearls that you can take home for your practice in the world of uveitis. So, and we have kept it as like a wide variety covering all the types of uveitis. So we hope you'll all greatly benefit from this. Let me invite my first speaker, Dr. Parthopratim Majumdar. He's going to speak to us on 10 pearls in the management of anterior uveitis.
Thanks, Natasha, for having me here. And good morning to all. So I'll be speaking on the 10 pearls in anterior uveitis. So the first pearl of decoding a case of anterior uveitis is know the keratic precipitates. As you know that the keratic precipitates are very important and sometimes can help you to differentiate between granulomatous and non-granulomatous uveitis. The granulomatous keratic precipitates are typically the mutton fat capes. Also, another important entity is that Fuchs uveitis, which is characterized by the stellate capes. But you must remember that these capes and all are, they add in your diagnosis, but they are not the telltale sign of any particular uveitic entity. Coming to this entity like Fuchs uveitis, it is considered as the most underdiagnosed and over-treated case of uveitis. It is often actually missed because we think that it's a heterochromic uveitis, but whereas that in Indian patients, the dark individuals, this kind of heterochromia is very rare. So because of that, you need to look at the pattern of the iris, which will give you the overview that you are dealing with a case of keratic precipitates. Now you see this case, 39-year-old male complaining of blurring of vision post-cataract surgery, diagnosed to have anterior uveitis, treated with topical and oral steroid for 3 months, pigment clumps on the cornea, and the aqueous aspirate showed that it's a methicillin-sensitive Staphylococcus aureus. So sometimes the chronic inflammation, chronic endophthalmitis can actually present with chronic inflammation, and you need to understand that not all keratic precipitates suggest inflammation. Next important sign you need to look is that iris atrophy. The iris atrophy usually indicates the viral anterior uveitis, whereas it can be seen in various other conditions. But few things which will give you idea that you are dealing with a viral uveitis is that unilateral involvement, corneal involvements in the form of some scar, the pigments or coin-shaped distribution of the keratic precipitates, and the raised intraocular pressure. So these are the signs actually will give you an idea that you are dealing with a case of viral anterior uveitis. Now, if you are getting a case of recurrent hyperacute or acute anterior uveitis, you need to suspect the HLA-B27 correlation. These are the HLA-B27 associated uveitis keeps on alternating between the eyes. They will have intense anterior chamber reaction. They present with hypopyon and may have the systemic association like ankylosing spondylitis, psoriatic arthritis, various other conditions. Now also, when we talk about the HLA correlation, you need to sometimes see that the hypopyon can be seen in Behçet disease also. But remember, these are the conditions. HLA testing does not rule in or rule out any particular conditions. You have to look for the other causes, match them into your diagnostic criteria, and then only you can come to a diagnosis. Now, fibrinous anterior uveitis, when we talk about that, you feel that it's always autoimmune or HLA-B27? No. You see this case of 36-year-old female presented with fibrinous anterior uveitis and scleritis. And if you see this picture, this patient was treated in the suspicion of HLA-B27 with oral steroid. But when we tested, the RPR and TPHA was positive. So it is important to understand that sometimes the syphilis can also mimic this kind of conditions. Now, this is another male blurring of vision, history of some dust particle while driving. But when we actually took the patient and taken for vitrectomy and vitreous aspirate, because there was a lot of vitreous exudates and all, so this was a case of fungal infection. So sometimes you need to understand that what is going on, what is the particular clinical entity you are dealing with. This is a 13-year-old girl, mother noted white reflex in the eye, and all tests were of negative, and ANA was positive, referred to a rheumatologist and was diagnosed as a case of GIA. So in children it happens because most of the time these children, they present with some of the complications, and complications are the presenting sign of the disease, so you have to be very careful while dealing with that. See here, this is a 2-year-old child with white reflex, again presented when the child developed cataract. Then the parents actually sought the ophthalmologist's opinion, and you can see that there is a nodular swelling over the wrist. So this, when we subjected to the heterozygous, not to gene mutation, it was found to be positive. So these are the variant which can mimic GIA, but these are actually the Blau syndrome we are dealing with. So you have to look for this systemic association while dealing with that. So you need to understand when you are dealing a case of anterior uveitis in children, that topical steroid is not the answer. You can't actually treat a pediatric uveitis with only topical steroid. You need to start on immunosuppressive and all. So HLA-B27 uveitis, you see, sometimes it can present with severe redness, irritation, vitreitis and all, and it can be actually present like panophthalmitis or exudative, endogenous endophthalmitis like picture, but these are the cases you need to understand. This is basically a anterior uveitic entity. Now, it's not just always anterior. You see, this patient was treated with mainly as an anterior uveitis. Lot of reactions in the anterior chamber, and you can see that it looks like an anterior uveitis. But the posterior segment is having severe vitreitis. We did the ACTAP, and ACTAP showed positive for varicella zoster virus. Similarly, another 6-year-old boy, you can see a lot of anterior chamber reaction, but if you look carefully, this was a case of ARN, because you can see the confluent retinitis patches or scattered 360 degree in the fundus. So these are the patient you need to identify, look carefully for the fundus picture, fundus signs, because there can be a associated posterior segment involvement of the retina, which can be missed if you don't pay attention to the fundus examination carefully. Now, sometimes you see this is a patient who presented with a anterior uveitis like picture, but if you carefully look here, you can see the some whitish mark in the lens. So this was basically a lens-induced uveitis. So these are the very important thing you have to know. This is another 77-year-old male. You can see here, this is basically a lens-induced uveitis. So you need to understand that lens-induced uveitis, the treatment is not the topical steroid or cycloplegic. You need to go for the lens extraction. Now, this is another patient. You can see they presented with large like exudates in the anterior chamber, and you see here that redness, irritation, everything was there, but it was a case of actually metastatic squamous cell carcinoma, and these are you are seeing that the metastasis which has presented an anterior segment picture. This is again an 8-year-old child. You can see here hypopion, not responding to topical steroid, and when we did the investigation, it's actually showing that high nucleocytoplasmic ratio. So these are the cases you need to be very careful about muscular syndrome. Now, coming to my last point, look for the cause of that uveitis. You have to always remember that there can be something different in the anterior chamber. You see here, this is a history of injury with a insect while driving a bike, and following that he developed anterior uveitis. And you see here, if you can, I don't know whether the picture is clear or not, you can some caterpillar here, and you see here, you can see that hyper-reflective spot. So these are basically caterpillar hair-induced anterior uveitis, and it has to be picked up early. Now, just last I will show one case. You see here, this is a patient, cataract phacoemulsification was done and the lens was placed in bag, and the following that the patient was constantly actually having the anterior uveitis. Now look carefully what went wrong. This happens when you make sometimes very large or eccentric rhexis, and the single piece IOL, though it is sitting in the bag, you can see here the edge of the square edge of the optic is out, and you can see here there. The schematic diagram is showing there how that square edge, if it is exposed, it can rub the iris and can cause significant inflammation. This is another case you see, same in the bag implantation, but large rhexis, the square edge is actually rubbing the iris and causing intense inflammation. Thank you for patience here.
Thank you, Dr. Partho, for that excellent presentation. Since we have time, if anyone wants to ask any questions to Dr. Partho. Yes, please. Help her with the mic, please, someone.
Yes, sir. In one of your case of HLA-B27 associated uveitis, like initially you suspected that, but then you said it, like when you did the vitreous tab, it was MRSA. But when there is no vitritis, then how we can label it as endophthalmitis? Aqueous tab, not vitreous tab, you said.
No, there was some posterior segment inflammation. So, but it was if you see that little bit of vitritis can be seen in HLA-B27 anterior uveitis also.
Yes, sir.
The referral doctor, he thought that he is dealing with HLA-B27,
yes,
and he was treating with that. But the patient when came to us, as you know, that already someone was treating with HLA-B27, not responding, and we could see that some atypical picture, like chronic inflammation, lumps, some vitritis haze is there. So that's why we did the AC-TAP, and it showed that.
Yes,
so the idea is that if there is a long-standing chronic inflammation is going on and not responding to any conventional therapy, is the time you should think differently, because infection can come with inflammation also.
Yes, sir. So, and also like in one of the trauma patient, like trivial trauma with dust during bike. So you said it is like it was endophthalmitis. So like how do you differentiate endophthalmitis with panuveitis with no history of trauma, no post-op? How you label that? Like what makes you define the label of endophthalmitis in such cases?
So this is a very challenging case scenario where you suspect between an endogenous endophthalmitis and a case of panuveitis. So sometimes you need to differentiate between those. Endogenous endophthalmitis patients will typically have some comorbidities, like they can have a long-standing diabetes or sometimes they will have a recent history of some procedure, like it can be tooth extraction or anything also. So, but these are the conditions clinically you can't diagnose that. So if you are not sure that you are dealing with a case of panuveitis, I always suggest don't go for invasive procedure, but at least try to do some basic workup like urine culture, blood culture, and this routine blood examination and all. And side by side, you just investigate the patient for your inflammatory markers and other things also. So then with that you have to take this. But I agree, these are some cases where it is extremely difficult to differentiate between panuveitis and endogenous endophthalmitis. I am not talking about exogenous endophthalmitis, which happens after surgical procedure or trauma.
Yes, sir. And so for caterpillar associated and like uveitis, we'll just remove the caterpillar and give the usual treatment?
Yeah, that's the actually standard treatment, but no, sometimes it's very difficult because these will be plenty of the caterpillar, so it has become difficult. So we try to treat the inflammation. Sometimes with anti-inflammatory treatment, it can actually resolve.
Yes, yes. And sir, HLA-B27, like even if it comes positive, if it's a anti-uveitis, one has to give like topical and the systemic therapy. Apart from that, how it makes a difference, like if somebody is HLA-B27 positive, because many times they don't have any like rheumatological problems.
Yeah, so sometimes it can happen that I can be involved even before the systemic associations are prominent. So in these cases, you have to use that. So HLA-B27 uveitis, if it is coming again, we know that we often call it like it behaves like a ping pong. It goes to one eye and then after sometimes it will come here. So the recurrent of uveitis, if it is less than 3 months and the patient is having recurrent attack of uveitis, this is the time even the patient is not having any systemic association, you have to start the patient on oral methotrexate.
Yes.
Or some other.
Yes. Thank you very much, sir. Absolutely beautiful talk. Thank you, sir.
Thank you, Dr. Partho. If there are no more doubts, we will go on. You have, okay.
So
Dr. Partho, one more question for you.
So we had a patient with the caterpillar hair in the vitreous cavity. The patient was asymptomatic. We just detected in indirect ophthalmoscopy. Is it necessary to remove it?
Caterpillar here.
Yeah, caterpillar.
Yeah, it's not necessary, madam. If there is any inflammation, then only we should
There
treat
was no inflammation.
Yeah.
And no symptoms also. Accidentally we detected patient came with symptoms in the anterior segment, but there is no inflammation in the vitreous or even in the anterior segment.
Yeah.
But after 2 months, he came with the one caterpillar hair in the cornea because it is migrating and
Yeah, I think it's better to inform the patient and explain him that these are the possible inflammation you can have in future. So if you have significant like floaters you can see, or if you have some blurring of vision, then immediately come because there is a caterpillar here. In a case of a asymptomatic with a proper 6/6 vision, I don't see any indication of doing a vitrectomy in such patients because unnecessary.
Sir, I have a question.
Can we stop the music for a minute?
You want me to sing? Dance. Or dance? Reduce it. There is a question here. Thank you.
Sir, in cases of HLA-B27 anterior uveitis, you told that it might come, while investigating it might be negative, but it can have systemic, like it can precede, the eye symptoms can precede the systemic. So do we always need to send those cases to dermatologists even if HLA-B27 is positive or negative?
No, not at all. Because if your rheumatologist is your friend, he is sending you cases, then you can send. Otherwise, why you will send? You can treat it. It's not necessary. So jokes apart, I feel always that sometimes you need to understand that these patients can develop systemic association later. Sometimes you think that it is HLA-B27, your HLA-B27 is negative. Now, one thing you must remember that what method they are doing. There are two methods. One is flow cytometry, one is polymerase chain reaction. So if it is done by the flow cytometry, then again repeat it with polymerase chain reaction. PCR is the most sensitive for HLA-B27. Also, you need to understand that the patients who are HLA-B27 negative can become positive after a variable period of time, like 4 years or 5 years time, they can be positive. So these two things are important.
Okay. So if they are PCR positive HLA-B27, even then we'll manage it by ourselves. We don't need to send.
Yeah, see, starting methotrexate is not a rocket science. You can actually, this is the only immunosuppressive you can start and sleep peacefully at night. These drugs are very good, safe. Imagine we are using for the pediatric uveitis. So just little bit of reading and all, just you need to know what are the things you need to explain the patient and try to take a proper medico-legal consent that the patient knows that what are the side effects and potential risks. That's
Okay.
it.
Thank you, sir.
Thank you.
Thank you, Dr. Partho. Now we'll move on to our next talk. It is by Dr. Mudit Tyagi, and he will speak to us on 10 pearls in management of infectious uveitis.
All right, so good morning. First of all, let me thank Dr. Natasha and the scientific committee for having me here and allowing me to talk on this topic. So I'll be speaking in a nutshell about 10 clinical pearls in infectious uveitis. Now the first pearl that we have to remember and the first rule of infectious retinitis is that every retinitis is infectious unless proven otherwise. So whenever you see a retinitis, the first thing you have to think of is you are dealing with some infection. Whatever might be the underlying etiology is a different issue altogether. But the rule is that it is infectious unless and until you are able to rule it otherwise. One of the most common non-infectious causes of retinitis is Behçet's. Very rarely sarcoidosis can very rarely present with retinitis, though usually it is choroidal. So otherwise every retinitis, golden rule, it is supposed to be infectious unless you can probably rule out all causes of infections otherwise. Now the second point in retinitis is a lot of times people do get confused whether you're dealing with a retinal involvement or a choroidal or a scleritis, and how can you identify that? So a very important investigation can be an FFA, a fluorescein angiogram. Whenever you are in doubt, can help you in identifying whether you are dealing with a retinitis or a choroidal lesion. And the things to look for are, number one, the intensity of early hypo, and then the pattern of early hyperfluorescence. So two things, intensity and pattern. So if you have got intensity of early hypofluorescence is maximum in retinitis, and I will show you the example, followed by choroiditis, and the pattern of early hyperfluorescence, that's very important. So retinitis will have a perilesional hyperfluorescence, whereas the choroidal involvement will have an intralesional hyperfluorescence. So let me show you how. So this was a patient of retinitis, and if you look at the initial hypo, the initial hypo is maximum in retinitis as compared to choroiditis. And now look at the pattern of early hyperfluorescence. The pattern of early hyperfluorescence, look at it, it is perilesional. Whereas over here you start seeing a diffuse intralesional hyperfluorescence. So whenever you see a perilesional hyperfluorescence, you can rest assured that you are probably dealing with a retinitis rather than a choroidal involvement. Scleritis is not that difficult to diagnose in terms of the fact that you will get pinpoint leakages and a T sign on your ultrasound B scan. But the point where a lot of people get confused is whether it's a choroiditis or a retinitis, and these clues can help you in identifying both of them. Now, clinical clues to some very common disorders which we have started seeing more and more in our clinics, and which should not be missed because these are obvious clinical diagnosis where you need to probably just order a lab investigation to confirm what you are dealing with. So, a placoid chororetinitis with more intense infiltration at edges. This is what you need to remember. You see a placoid chororetinitis lesion and you see more intense infiltration over here at the edges. Get an OCT through that and you see this photoreceptor damage and RP nodularity. Put both of these together, you are probably dealing with ocular syphilis. So that's one clue to diagnose ocular syphilis. The other patterns to diagnose syphilis are if you see these multiple miliary lesions. We are not talking of vitreous opacities here. We are talking of retinal multiple miliary lesions. So you see them and you do an OCT and you see that it's got a full thickness retinitis. So miliary lesions with full thickness retinitis, or a ground glass retinitis like you see this diffuse hazy sort of a retinitis with a central clearing sometimes. Now you see these patterns, these again are clues to the presence of an underlying ocular syphilis. And remember, ideally all patients of uveitis who present to you, at least that's what we do, should be tested for syphilis. So we get all of our patients tested for TPHA, which is a treponemal test which stays positive, as compared to VDRL, which has got only 70% sensitivity. So we have actually made this mistake earlier. There was one patient who we only got tested for VDRL, came negative. We never even entertained the diagnosis of syphilis and started this patient on steroids. When the patient worsened, that's when our the bells rang, and we got the patient now tested for TPHA, and we found TPHA to be positive. Subsequently, we have now found that nearly 20% of patients can be VDRL negative but TPHA positive. So the rule is, get your patients tested for the treponemal test like TPHA first to diagnose syphilis. VDRL titers can be used to monitor the response to treatment. So a 4-fold reduction in your VDRL titers along with the resolution of your clinical picture together constitutes the definition of a cure in cases of ocular syphilis. So first thing, remember the clinical patterns. If you see this placoid chororetinitis and RP nodularity on OCT, if you see these multiple miliary lesions or a ground glass retinitis, these are clues to syphilis. Get your patient tested for TPHA. If that comes positive, then you are on the right track. And the good part about syphilis is the one disease which we can completely cure. So patients with poor visual acuity end up having a miraculous recovery to as much as 20/20 in a lot of these cases. Moving on to identifying toxoplasma. Toxoplasmosis is usually the most common cause of a unifocal retinitis lesion. So if you see a single unifocal retinitis lesion, in most cases, you are dealing with a toxoplasmosis. Get an OCT through that, you will see a chororetinal involvement. The other point to remember is that in cases of reactivation, a reactivation of toxoplasma usually always occurs from the edge of a scar. So remember that if you see a patient with a pigmented lesion over here like what you see over here and you see a retinitis lesion adjacent to it, rest assured that you are really on the right track. You are probably dealing with an ocular toxoplasmosis and nothing else. So reactivation from the edge of scar, unifocal retinitis lesion, most commonly toxoplasma. The other thing to remember is what all can also happen. So a lot of times toxoplasma can cause an intense vitritis, what we used to call the headlight in fog sort of an appearance. But remember, intense vitritis is predominantly seen in two other diseases or two other conditions. One is ARN and other is pars planitis. But if you see through that vitritis and you can see a central lesion somewhere through that retinitis, through the vitritis, you are dealing with toxoplasma. If through that hazy vitritis you are able to see some lesion in the periphery, around the ore or in the margins, then probably that's an ARN. So the two most common causes of a dense vitritis otherwise are, in terms of ocular infections or uveitis, are toxoplasma and ARN. The other causes sometimes can be an endogenous endophthalmitis, which you need to rule out again. But otherwise, if you can see through that fog a central retinitis, a central yellowish sort of a lesion, toxoplasma, if you see that central yellowish sort of a lesion in the periphery, probably ARN. Now also remember, occasionally toxoplasma can also mimic with an ARN-like picture. Actually, it's called an atypical toxoplasmosis is what most of people label it, but it's easy to diagnose these also if you look at them carefully. Now this was a patient actually who was treated as a ARN, was given intravitreal ganciclovir before the patient came to us. But the point is, if you look carefully, you will see this triangular sort of a retinitis, but more importantly, if you look carefully, what you will also see is this pigmented scar adjacent to it. So just remember what I told you 5 minutes back. Toxoplasma usually gets reactivated from the edge of a scar. So this actually was not a case of a viral acute retinal necrosis, but this was an atypical toxoplasmosis in this patient. So if you see a scar and then you see a retinitis lesion adjacent to it, that's a very important clinical pearl in identifying toxoplasma. Moving on to another lesion which can occasionally present with a unifocal lesion, but if you look at it, you will be able to appreciate the fact that it is probably seeding into the vitreous. This is how usually Candida endophthalmitis presents with. So if you see a patient who now probably also gives you history of some intervention done earlier, like what Dr. Partho said, that patient gets a history of a tooth extraction. This was actually a lady who had undergone a hysteroscopy 3 weeks back before she presented to us. And you can see this lesion, you can see this multiple string of pearls or bead sort of an appearance in the periphery, multiple few small vitreous exudates, but more importantly the central unifocal lesion. And if you do an OCT through this, you can see something erupting through the OCT. So you see this large, this is called a rain cloud sign, which is seen on OCT, which is pretty characteristic of Candida. So you see this lesion which is protruding through the vitreous, and beneath that you cannot see the underlying retinal layers. That is the thing which you need to remember. There are times when people have erroneously labeled just some vitreous exudates as a rain cloud. That's not what rain cloud is. Rain cloud is a lesion which is now from the choroid, that's how endogenous endophth spreads, like from the choroid to the retina to the vitreous, and you cannot see the underlying retinal or choroidal structures underneath that. So that's a rain cloud sign which you can see over here. Unlike that, aspergillus usually will have a deep retinal with horizontal enlargement. So Candida may have a unifocal single solitary lesions in a lot of cases, or sometimes even 2 lesions, but they will not be horizontally widespread. And you can occasionally have a hemorrhagic vasculitis along with it. So if you diffuse widespread sort of a lesion, which is sub-RPE and subretinal space is involved, that usually is how aspergillus endophthalmitis presents with. Now the other clue, other disease which you should learn to identify, which can be a big masquerade, is an intraocular lymphoma. So you see a patient, usually elderly patients who may come to you with significant vitritis, multiple vitreous clumps, that in itself should set the alarm bells ringing. Is it something else rather than a typical uveitis? So dense vitritis or multiple vitreous clumps, clue number 1. Multiple yellowish sub-RP lesions, if possible, sometimes even an optic nerve infiltration, again should alert you to the fact that probably you are dealing with an intraocular lymphoma. Also, sometimes the history can be very characteristic. You may have a history where the patient has been given steroids, the lesions resolve, and then sometimes later the vitritis comes back again the moment steroids are discontinued. So if you are seeing recurrent inflammation in an elderly patient with vitreous clumps, think of a possibility of an intraocular lymphoma. Also, these clinical lesions need to be appreciated and understood. So if you see these creamy yellowish lesions with deep infiltrate, some pigmentary changes over here, what you call a leopard spot, and if you do an OCT, you see this RP nodulated and this sub-RPE infiltration. So this sub-RP infiltration, if you see that, that is also very characteristic of an intraocular lymphoma. So you see a patient who has got this well-defined subretinal lesion, which is called a leopard spot, and you see this sub-RP infiltrates. Probably you are dealing with an intraocular lymphoma, so this should be something you should be aware of, and we should keep at the back of our mind that this probably can be an underlying lymphoma and not something else. Now moving on from infection, some non-infectious entities which have been labeled as infective. So this is what you should be aware of. Do not let masquerades fool you, or be aware of the masquerades. So this was a patient who was labeled as a retinitis and referred to us before that somebody had actually started this patient on steroids, but look carefully, you see this yellowish lesion, but through that you see these two small areas of lucency. So if you see a yellowish lesion and through that you see these two small lucent areas, that probably is a CSR, and what you are seeing as this yellowish thing is nothing else but a subretinal fibrin. The best investigation to be done is probably an FFA, and a fluorescein will show you multiple leaks. But an OCT in itself can help you. So you get an OCT, then you see this PD, and you see this area of lucency through that area of fibrin. So remember, sometimes masquerades can mimic, and you should not just go on a one-track mind. You should keep your mind open to differential diagnosis. And I'll come to my last pearl, which is again a masquerade. Remember, a hypopion, again in patients who are getting treated for tuberculosis, may not necessarily mean a reactivation of the infection. Ask or look for a careful drug history. If your patient is taking rifabutin, then anterior uveitis is known to be a drug dose-dependent effect of rifabutin at a dosage over 300 milligrams. So it may even present with a unilateral or occasionally a bilateral hypopion, and this hypopion will resolve the moment you discontinue rifabutin. So keep in mind the fact that you may be dealing with the other entities also. Be aware of masquerades and look for these clinical clues or pearls which will help identifying retinitis much more simpler than what we think it is. Thank you.
So thanks, Mudit. Wonderful, wonderful talk. Any question from the audience? So next I invite my good friend, Dr. Natasha Radhakrishnan. So Natasha is known for her pioneering work in pediatric uveitis, especially the cubes, the childhood uveitis blindness support she started is an eye-opener for many of us, including all ophthalmologists. So Natasha will be speaking on 10 pearls of pediatric uveitis. Over to you.
All, a very warm thank you for attending this session early in the morning on a Sunday. And let's go quickly into the topic. So as you all know, childhood uveitis is not a very common disease, but you have an incidence of 3 in 1 lakh in 0 to 4 years and about 6 in 1 lakh in 10 to 14 years. But it is the most difficult to treat, and it can have blinding complications. The commonest types of uveitis by age, in the early years, it is the JIA, chronic anterior uveitis. In the later years, it is idiopathic chronic anterior uveitis and intermediate uveitis. And in an older age group, it is usually a B27-associated acute anterior uveitis. We follow the same classification for pediatric uveitis that we do for adults. And the features of anterior uveitis, intermediate uveitis, and posterior uveitis remain quite the same, like the keratic precipitates, which may be granulomatous or non-granulomatous, festooned pupil, the posterior subcapsular cataract, pigments on the anterior lens capsule, a specific thing that we see in pediatric uveitis, which is the band-shaped keratopathy. Causes, just like in adults, can be myriad. It can be a lot of causes which may be infectious or non-infectious, and each of these anterior, intermediate, and posterior have a long list of causes. Let us go one by one into the pearls that we can gather from here. In case number 1, an 8-year-old boy presented with decreased vision in right eye for 2 months with no redness, pain, fever, joint pains, or any other systemic symptoms. 2/60 vision in the affected eye, early band-shaped keratopathy, festooned pupil, but mature cataract. So there was no view into the vitreous. And the B scan showed a few coarse vitreous echoes, no RD or tumor or choroidal thickening, and was referred to the immunologist to rule out JIA, but there was no evidence seen. Basic infective workup was also negative, so we took up for cataract surgery after giving some basic immunosuppression. Underwent cataract surgery with IOL implantation, but found to have a large granuloma-like lesion in the periphery. So this patient had a toxocara granuloma, which was then later confirmed in histopathology because the patient developed an RD, and we went in and settled the RD. So pearl number 1 is, whenever you think of pediatric uveitis, we tend to think of anterior uveitis. But pediatric uveitis can involve the posterior segment, so always do a dilated examination in a pediatric child before you label the patient as an anterior uveitis. And especially in children, you may require to do an examination under anesthesia. That is something that we cannot avoid. So before you start and before you label the patient, before you send for investigation, see that you do a dilated fundus examination, if needed under sedation or anesthesia. The second one, Mudit had put this right at the last of his slides when it came to adult patients, but when you're dealing with pediatric uveitis, I would put it right in front, because this is something that if we miss, nobody is going to find it. So we have to absolutely not miss this. A lot of conditions can masquerade as uveitis. In children, we should remember about retinoblastoma and juvenile xanthogranuloma and sometimes the leukemias. And as you can see from the pictures, they can very much look like uveitis, both anterior and posterior. So have a high index of suspicion for masquerades and be sure that you're dealing with uveitis itself before you refer the patient to a pediatrician or a rheumatologist. Next, we go on to the most common systemic association of pediatric uveitis, which is juvenile idiopathic arthritis. It is asymptomatic disease and it is detected on screening and sometimes accidentally, and it can be a presenting finding in juvenile idiopathic arthritis because a little bit of joint pains in children are always dismissed as growing pains, or the mother says it will go off after some time, take some rest, give some maybe paracetamol syrup. So you may be the first person to actually diagnose this condition. And you know that they all present with this very typical band-shaped keratopathy and cataract with multiple posterior synechiae. Many of them develop secondary glaucoma. Sometimes as a posterior segment complication, you can have macular edema and later amblyopia, and in the last stages of the disease, severe hypotony as well. So in JIA, points to remember are, it is usually anterior, very rarely pan-uveitis. It is usually a white eye with chronic course. Systemic JIA diagnosis is not a blood test. It is criteria-based, so you will need your help from a pediatrician or a rheumatologist for diagnosis. Methotrexate and oral corticosteroids are the first line, and you may add MMF later, and in adalimumab in refractory cases. This was how we used to deal with it earlier, but now more and more we are shifting to first line adalimumab because it has excellent results in pediatric JIA uveitis. Topical medications have only an adjunctive role, and slow tapering of topical steroid with constant monitoring for the eye activity and IOP is absolutely essential. We all know the risk factors: females, oligoarticular arthritis, young age, ANA positivity, RF negative. So in a high-risk JIA, you need a 4-monthly screening, and in a low-risk JIA, 6-monthly. So my pearl number 3 for you is that topicals are not the mainstay of treatment for JIA uveitis. So if you have a child who has an asymptomatic anterior uveitis with sequelae, you have no business starting the patient on topicals alone without sending the patient to a pediatrician or a rheumatologist for evaluation and, if needed, systemic immunosuppression. And pearl number 4 is that all JIA patients should be evaluated with a slit lamp examination. And if the patient has been sent to you for screening, you cannot send the child back without doing a slit lamp examination for the child. Juvenile spondyloarthropathies make up 15% of pediatric uveitis and include juvenile ankylosing spondylitis, Reiter's, psoriatic ulcerative colitis, and Crohn's disease. Most of these are acute and symptomatic anterior uveitis and often with a hypopion. And unlike the other, there are some other points to remember. Unlike the JIA, boys are commonly affected more than 8 years of age. It is an acute recurrent uveitis that is bilateral and asymmetric. Many are positive HLA-B27, and they present with sometimes hypopion. IBD, as you know, Crohn's and ulcerative colitis come under this category. So not all pediatric uveitis are asymptomatic, and when you have a symptomatic presentation, it is probably not JIA. You cannot say hard and fast, but probably not. Now this baby, 10-month-old female baby, presented with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight, had a lot of systemic findings: edema, depigmented hair, hypopigmented scaly lesions, and the eye had bilateral anterior uveitis with festooned pupil and cataract at 10 months of age. And investigations showed systemic granulomatous inflammation, and was diagnosed to have infantile sarcoidosis and started on systemic immunosuppression. Furthermore, when underwent cataract surgery, is under follow-up. So infantile sarcoidosis, the points to remember are it is an early onset disease. It can occur in approximately half of the cases. You will need liver biopsy, and it presents in the first year of life with a characteristic triad of uveitis, rash, and arthritis. And it is what you should keep in mind if a very early onset uveitis comes to your clinic. And the differential diagnosis is a condition called the Blau syndrome, which is juvenile systemic granulomatosis, which is familial. And you have the NOD2 mutation positivity. So very early onset severe uveitis with sequelae, think of infantile sarcoid or Blau syndrome. Behçet's uveitis. Now, pediatric Behçet's is onset of uveitis at 16 years of age or younger, and you may think it is very uncommon, but it is not. And we can get pediatric Behçet commonly in our population. The mean age is late childhood, male preponderance, bilateral involvement, recurrent panuveitis with retinal vasculitis and HLA-B51 positive. Pearl number 7, 1, it is more common than we think, and 2, it is a clinical diagnosis, and the HLA-B51 has only a very supporting role, which is something we must keep in mind. Now, going on to management of pediatric non-infectious uveitis, you will all agree with me, all pediatric non-infectious uveitis has to be investigated, rule out masquerade, assess activity and sequelae, and take a pediatrician or a pediatric rheumatology help. So topical steroids are initially used, but you have to hit hard, hit early, but they should not be the mainstay. Children can have a very high incidence of steroid-induced hypertension, so we have to keep our eyes open for that and try and taper and stop the topicals as early as possible. Now, sequelae, cataract surgery has to be done. You can use posterior chamber intraocular in the bag implantation, but always remember, ensure an activity-free period of ideally 6 months before you take up for cataract surgery. Steady systemic immunosuppression and give steroid cover at least 2 weeks prior and continue for a month after. Slow taper of both systemic and topical. Do not taper like you taper for your adult patients, and you may need to continue maintenance topicals for even more than 6 months. Remember to use more caution. If the patient is hypotonous, then you must try and reduce the hypotony. Use a stronger steroid like difluprednate to bring the IOP up a bit, control the inflammation well before you take up, or you will end up with a Thuysical eye. Uncontrolled inflammation with vitritis or retinal involvement, it is better to leave it alone without placing the intraocular lens. Leave them aphakic with a lensectomy and a vitrectomy. And never ever operate pediatric cataracts without adequate immunosuppression. BSK is much easier to treat. EDTA or phototherapeutic keratectomy can be done, but it keeps coming back if your inflammation is not controlled. Cystoid macular edema, like in adult patients, we treat with either posterior subtenon or a dexamethasone implant if it is not going away with just control of the inflammation. Secondary glaucoma, we have a long talk on glaucoma following in the next session, so I will not go into that, but you can treat with topicals. If it is refractory to topicals, then you can take up for mitomycin C trabeculectomy, or mostly they require valve surgeries. The last case, 12-year-old girl, bilateral panuveitis with vitreous haze, complicated cataract, and BSK. Vision is hand movements in the right eye and 6/60 in the left eye with hypotony, ciliary shutdown, and this is how she presented to us. After control of immunosuppression, she underwent cataract surgery with vitrectomy and oil and is maintaining a vision of 6/12. So finally, you may not be able to treat all of these cases with just anterior segment surgeries. You may need vitrectomy, sometimes for diagnosis, sometimes therapeutic. And with small gauge vitrectomy, now we have very less morbidity in children, and you can take up these children for surgery without much difficulty. So in conclusion, pediatric uveitis is like an obstacle course. The road is long and arduous. Hurdles and unexpected twists and turns are there because it's a long journey that we have with our patients. But finally, it is rewarding when they are happy and they can draw and see the world. And this is a small thing that I have started in the world of pediatric uveitis. It is called Childhood Uveitis Blindness Trust. Because of these children require a lot of financial support since they have a long-term treatment that is required. We inaugurated it in the annual CME called Ignite at Kochi, and it's doing well. I will be happy to share the details with anyone who would like to help us in the way of contributions. Thank you all for a patient hearing, And thank you to Namrata ma'am and AIOS for giving us this opportunity.
Yeah, thank you, Dr. Natasha, for wonderful talk. I just wish to ask you and same to Dr. Mudit sir in reference to adult patients. Nowadays, with the availability of quantiferon TB Gold test and like previously also we used to do Montox, sometimes it becomes difficult to decide when to suggest pulmonologist to start on ATT. So if a patient is having like not very clear picture in favor of ocular tuberculosis, but yes, anterior segment or posterior segment inflammation is there. And if quantiferon TB Gold test positive, Montox positive, chest X-ray not in favor of pulmonary TB, then how you decide on to start with ATT?
So the first thing is you do not treat a test, you treat a patient. You treat it in conjunction with your clinical science. What does a MONTO tell you? It just tells you that at some point of time or life, you have been exposed to the TB antigen and your body has developed antibodies against it. That's what MONTO tests. The same principle nearly holds true for quantiferon. So you are not treating your patients on the basis of your MONTO or your quantiferon. You treat them in conjunction with the symptoms that you are having. So if your patient has got clear-cut signs or patterns of a subpyginas like choroiditis, your life is easy. If you have got vasculitis with subvascular CRA patches, again you know probably you are dealing with ocular tuberculosis. If you are just isolated seeing intermediate uveitis or just a vitritis, that is where the dilemma starts. I would probably not treat them just on the basis of a positive MONTO. Get a CCT chest done, not a chest X-ray. A lot of times people get an X-ray done which usually does not pick that much details. If you can possibly get it done, get a contrast enhanced CT. That will also help you in looking at what is happening over there. So if all of those signs are possibly corroborating, you may still start them on ATT, but not otherwise.
Sir, if CCT negative and only anterior segment or only vitritis,
I
then
do not treat my patients with vitritis with an ATT to start with, just because their MONTO has come positive.
You should have the features that have been told as typical of tuberculosis in the eye with a positive test if you want to start TB treatment. If you have not so typical features, you have generic uveitis, like you said, anterior intermediate uveitis, and you do not have any systemic evidence of TB, you do not need to start ATT. Yes.
okay. Thank you, sir. Thank you, ma'am. And thank you, Mudit sir, for wonderful talk. Thank you, sir.
How we investigate the cases of GIA?
We cannot investigate, sir. It is a clinical diagnosis with a lot of criteria. It is a criteria-based diagnosis. So what we usually do is the pediatrician or the rheumatologist will be able to guide us. There is no test that we can do to diagnose GIA.
Thank you, ma'am. Thank you, ma'am, for that wonderful talk. I have two questions. One is, in a case of pediatric uveitis, you told we have to start systemic immunosuppressants before taking up the patient for a cataract surgery. So do you take any specific, like an IV MP or something just before doing a cataract surgery and post-op?
No. IV methylprednisolone is not required. If the patient is on adequate immunosuppression and you have a disease-free interval of 6 months, which means there is no cells in the anterior chamber for 6 months, then you can take up the patient with the age-appropriate dose of systemic steroid. Usually our rheumatologist starts about 2 to 3 days prior to the cataract surgery and then takes the patient up for surgery.
There is no IVMP before
not
that.
required,
Okay.
unless you are taking up the patient when the patient is having like severe inflammation for whatever reason. Sometimes you are not sure of the diagnosis or very hypotonous eye and you want to take up, then they may recommend IVMP, but generally not.
Okay. Then the second one, in a case of pediatric JAIA, so till what age you will follow up if the patient is not having uveitis? Like,
usually by 15 to 16 years, if they are not having uveitis, you can stop your follow-up.
okay, thank you.
Next. Okay. So if we have done with the doubts, we will go on to our next talk by Dr. Anju Kuriakos. She is going to speak on 10 pearls of non-infectious posterior uveitis. Over to you, Anju.
So good morning to one and all present here. I am going to, since Modi sir has extensively covered about the infectious posterior uveitis, I will be going into the details and pearls of non-infectious posterior uveitis. This is pearl number 1. Almost always non-infectious posterior uveitis has autoimmune etiology according to the literature. So most common association is with sarcoidosis, VKH, Behçet's and birdshot chorioretinopathy. So next we will be going into the symptoms per se for posterior uveitis. Most common symptom will be floaters and blurred vision in case of posterior uveitis. Next into the fundoscopic clues, examination findings. First one will be vitritis, most commonly with vitritis, choroiditis, vasculitis and disc edema. Vasculitis can be of peripheral arterial involvement, venous involvement and both involvement. Next most important is the multimodal imaging, which is mandatory. First, most commonly done is a fundus fluorescent angiography to look for vascular leakage, and this is not only for the diagnosis and for this is also for the follow-up. Next will be ICG to look for the choroidal lesions. As seen in the picture, we have to look for the number. This is also for the follow-up, not for just for the detection, also for the follow-up. Next, most commonly available non-intervention is OCT macula, which to look for cystoid macular edema, which is considered as the most common cause of drop in vision in case of an posterior uveitis. So this is the most common ancillary test multimodal imaging done in case of a posterior uveitis, that is fundus fluorescent angiography, ICG and OCT macula. Next, fifth pearl is, this is more common for all the cases of posterior uveitis. Now, how can we make it as non-infectious? So for that we have to rule out infectious causes. First, since we are in a TB endemic country, first thing to be ruled out is TB HIV, and next is the most common masquerade, syphilis, CMV and toxoplasmosis, which is also can present with most commonly seen as a posterior uveitis. Sixth pearl is, as we have dealt with the investigation ancillary test and ruled out the infectious causes, next is first line of treatment will be steroids. We will start with the steroids till the after the blood results are out, investigations are out, and with, since it is a non-infectious posterior uveitis needs a long-term follow-up and maintenance. With the steroids, we will also start the patient on immunosuppressives. By the time we taper the steroids, immunosuppressives will take up the action. Most commonly used are methotrexate and azathioprine for long-term control and maintenance. After all this, now the newer trend is biologics, especially for the pediatric uveitis, as discussed by Natasha ma'am. Most commonly used is adalimumab, infliximab and tocilizumab. So next, the most common cause of drop in vision in case of posterior uveitis is cystoid macular edema, for which early detection and prompt treatment is needed, for which we either give posterior subtenon or dexamethasone implant, which will relieve the symptom of the patient. 10th pearl is the follow-up. For a patient who has to be on long-term treatment with steroids and immunosuppressive, follow-up and counseling the patient about the nature of the disease and the condition, the need of immunosuppression, the need of follow-up, maintenance of the drug, almost has to be discussed in detail with them. This is mainly to monitor the recurrences with the FFA and ICG and to manage the complications related to the steroids or because of the immunosuppressants. So these are the 10 pearls. I will be summarizing it. First one is autoimmune etiology. Second will be the symptoms which they come with floaters and blurred vision. Third one is fundoscopic clues, which includes vasculitis, choroiditis, CME. Next is multimodal imaging is essential. Next, the main thing is to rule out infectious causes. First line of management will be steroids. After that, we will be shifting to steroid-sparing immunosuppressants and biologics for refractory cases. CMV is the most common cause of vision loss, so prompt treatment for this and regular follow-up is crucial. These are the 10 pearls in non-infectious posterior uveitis. Thank you.
Thank you, Dr. Anju. If there are any questions. So non-infectious posterior uveitis is one of the things that require long-term treatment. So most of us will have our non-infectious posterior uveitis patients with us for a long time, just like we have in pediatric uveitis. But on the whole, more rewarding and more easier to treat because they respond very well to our immunosuppression. So one of the complications that we find very difficult to manage as uveitis specialists is the glaucoma that we keep encountering, partly because of the uveitis and partly because of our treatment itself, because especially in children, they develop a lot of steroid-induced ocular hypertension, it will be called, because they don't have all the findings of proper glaucoma. But it's one of the things that vexes us, and it is not often touched upon in a glaucoma, in a uveitis session. So this time we have invited our glaucoma specialist, Dr. Jayashree PV, to speak to us with 10 pearls in the management of glaucoma in uveitis. Over to you, Jayashree.
Good morning all. At the outset, I would like to thank Dr. Natasha ma'am and APAO for the opportunity, and I do not have any financial interest in the topic being presented. So, we all by now know that glaucoma and uveitis do coexist. And first pearl is that uveitis is the second most common cause of secondary glaucoma, second only to cataract and cataract surgery related complications. If we consider all causes of uveitis, 10% of all the uveitis have glaucoma itself, uveitic glaucoma. I am not talking about uveitic hypertension, ocular hypertension. Higher prevalence of uveitic glaucoma is seen in anterior uveitis, older aged presentation of uveitis, and chronic inflammation. So by now we are familiar with two terms, uveitis related ocular hypertension, where you just have an increased intraocular pressure, there is no disc damage and there is no corresponding visual field defect. But when you have a disc damage and a corresponding visual field defect, you call it uveitic glaucoma. So there are two different entities. So when you see a patient of uveitis, you have to keep an eye on the eye pressure. Do look for disc changes also. Do look for NRR, neuroretinal rim changes. Look for RNFL defects. And definitely have a timely IOP and glaucoma management. Watching the disc and also doing visual fields for disease identification and progression is quite essential. But it is not as easy as a primary glaucoma. This is because many of the uveitis patients are symptomatic at presentation. They usually tend to do poor visual fields because of the symptoms itself and because many have poor vision. And the view to the disc itself is hindered by the opacities, and hence glaucoma detection itself is challenging. The second pearl here is one size doesn't fit all. What it means is there are varying causes for uveitis and the mechanism of glaucoma also varies. But it is essential to find it because clear diagnosis and appropriate therapy depends upon that. Based upon the angle structure, glaucoma is either open angle or angle closure. Based on the cause, it is acute or chronic. Based on the severity, hypertensive uveitis or post-inflammatory glaucoma. Based on the uveitis, non-granulomatous, granulomatous. Based on the cause, infectious, autoimmune, systemic, idiopathic. And there is a better classification. Based upon the IOP and inflammation correlation, you have inflammatory ocular hypertension syndrome, where the examples are herpes, Posner, Schlossman, etc., where you have the inflammation and the IOP peaking and coming down together. When there is an acute uveitic angle closure, the inflammation and the IOP peaks together. The inflammation comes down, but the IOP does not come down along with that, because when the angle closure comes down, when the angle closure reverses, at that time only the IOP comes down. When you have corticosteroid-induced ocular hypertension, what happens? The inflammation sets in. You start steroids, but once with the steroids, the inflammation comes down, but the IOP goes up. The timeline is shown in the x-axis of the picture. What happens in chronic mixed mechanism ocular hypertension is that there is waxing and waning of inflammation, and slowly the IOP starts to increase, and constantly the IOP remains elevated if not intervened. The third pearl here is about Fuchs heterochromic iridocyclitis. As previous speakers have spoken, we see that it behaves little differently. It's a chronic non-granulomatous low-grade anterior uveitis with insidious onset. It is mostly unilateral. Some might have bilateral disease. It is characterized by diffuse small stellate KPs. Posterior subcapsular cataract is there, but secondary open-angle glaucoma is common. Amsler sign we might have heard about, which is the trickling of blood from the angle when you do gonioscopy, AT, or when you do decompress during cataract surgery. It is characterized by no synechia, posterior synechia or peripheral anterior synechia formation. Heterochromia is there. This is the Amsler sign. They are different because there is poor response to steroids, so you don't have to load the patient with unnecessary steroids to produce a steroid response. Controlling inflammation as such is not correlated with effective control of IOP. In many of the Fuchs cases, IOP control is not achieved by medicine and surgery will be required. Many of the patients has a viral etiology. So if the viral etiology is proven with PCR, treating with systemic virals helps in IOP control also. So is PCR a saver? That is the fourth pearl. AC tab for PCR for viral DNA, especially in atypical presentations and unsatisfactory therapeutic responses. It is important because it differentiates the infectious from the non-infectious and identifies the agent. So if you target the agent, then again control of IOP gets better. Topical antivirals may be useful in keratouveitis, but as such not in uveitis alone. Then other pressing question is prostaglandin analogs useful in uveitis or not? Definitely prostaglandin analog like latanoprost, travoprost and bimatoprost are pro-inflammatory, agreed, and should not be used in active inflammation and viral uveitis because they definitely increases the risk for reactivation, especially in this herpes and CMV viruses. There is risk for reactivation and should not be used. But they are quite okay to be used in quiet eyes and non-infectious type of uveitis. What about PG analogs if you have an NSAIDs, topical NSAIDs being used? Topical NSAIDs inhibit prostaglandin, and hence the effect of prostaglandin analog will be less when you have a topical NSAIDs. What about pilocarpine? Cholinergics are contraindicated because breakdown of blood-aqueous barrier happens. It promotes posterior synechia. Brimonidine. Brimonidine is also found to be pro-inflammatory. So if you have an inflammation going on, in spite of appropriate treatment, and if the patient is on brimonidine, you can have a suspicion of brimonidine being pro-inflammatory in that patient and can stop brimonidine for that patient. Usually what happens is that this pro-inflammatory action in this brimonidine sensitive patients, they also have surface issues. So that will be a clue for that. What about the new Rho kinase inhibitors like ripacidil and all? They also have this anti-inflammatory effects along with this ocular hypotensive effects, so that the Rho kinase inhibitors are also useful. So drug of choice, the first line are those who reduce aqueous production, the topical carbonic anhydrase inhibitors and beta blockers. Second line will be alpha agonist and Rho kinase inhibitors. Of course, when there is the eye is quiet and that is a non-viral uveitis, prostaglandin analogs is okay. Contraindication is for cholinergics and like pilocarpine. If you had a sudden acute elevation of IOP with very high IOP, systemic carbonic anhydrase inhibitors and hyperosmotics are indicated. when to and when not to shoot. So when a patient presents with secondary angle closure, as in VKH syndrome, here what happens is not pupillary block, it is the ciliocoroidal effusion, ciliary body swelling, and we can see that the ciliocoroidal effusion leads to ciliary body swelling and angle closure. What you should do, after treatment, you see that the ciliocoroidal effusion has resolved, the ciliary body swelling has resolved, and the angles have opened up. Here we have not given pilocarpine, we have not done laser peripheral iridotomy. What we have done is treatment of the VKH and have given cycloplegics. So we need to identify when to shoot, when not to shoot. But in these conditions where it is a frank pupillary block, iris bombay, we have to give them proper treatment with laser iridotomy. This frank iris bombay, you don't have to treat as in a PSCS or PAC, primary angle closure. You can directly go ahead and give a laser iridotomy. At the most convex portion, directly penetrate with the first shot itself. You have to have a large PI and you have to give multiple PI also, because it could be a loculated, multiple loculations of the and because of the inflammation, these PIs tends to close off. Coming to the steroids, steroids are known to be the double-edged sword. It needs to be given for the inflammation to be controlled, but many patients are steroid responders. So it decreases the outflow facility. It's least with the systemic steroids, most with the topical and the periocular steroids. Triamcinolone and prednisolone has the highest steroid response. Loteprednisolone, fluorometholone has least likely, usually 2 to 6 weeks after starting. But if the patient has already had a previous episode of steroid response, the next time when you give, it can actually manifest even the next day of starting steroids. So if the patient has developed immediately after starting steroids, it does not rule out a steroid response, because if the patient has earlier had a steroid response, it could immediately have a steroid response again. The risk factors again is unrecognized POAG, family history of glaucoma, extremes of age, both young and old, diabetes and rheumatoid arthritis. What is the cause? Because of the biochemical and the morphological changes in the trabecular meshwork. And what happens if you stop steroids at the correct time, the trabecular meshwork changes back, reverse back, and the IOP is going back to normal. If you give depot steroids, you have to follow up the patient very early at 1 week. If it is topical at 2 weeks, if it is systemic at 4 weeks. Management, shift the patient to lower potent and newer steroids, or switch the patient to immunosuppressants or biologics if long term is required. If it is a depot steroid that is like subtenance that is given, then you have to excise that steroids. And if it is an intravitreal in Ozurdex, you can do vitrectomy to remove that Ozurdex. But if it is actually indicated, if the Ozurdex needs to be there in place, then you can go ahead and do a trabeculectomy. What we have seen is that trabeculectomy works better if there is a cover of steroids. So the next pearl will be, first establish the cause, see what is the underlying pathology and treat accordingly. If you have a turbid aqueous trabeculitis, you treat the uveitis, manage with the anti-glaucoma medication. Iris bombay, if you have an iris bombay, whatever amount of medicine you give without a PI, it is not going to revert. Steroid induced, remove the steroid, give an immunosuppressant. And if at all with this medicine management, it is not getting control, you have to opt for surgery. All is not lost when medicine fails. You can do surgery, trabeculectomy with mitomycin C, under steroid cover, that is very important, and antiviral cover if it's a viral cause is detected. There is an increased risk of failure both on the hypotony side and also bleb scarring side. Both the type of failure can happen in uveitis, and hence better success is seen with drainage implants. We have two types of drainage implant. One is with valve and other is the non-valved ones. Valved ones are preferred than the non-valved ones. That is because valved ones, the risk chance for hypotony is less. We are always more worried of hypotony because of the ciliary shutdown, all those issues in uveitis. What about SLT, that is laser trabeculoplasty? It sets in more inflammation and hypotony risk is more. So it is not that preferred as in any case of open angle glaucoma. the newer mix, that is minimally invasive glaucoma surgery. In that, there are some procedures we call stenting. Small stents are put in the angle of the eye, but they tend to get blocked because of the inflammation and fibrosis that happens. The canaloplasty, which we call the cutting surgeries, that tend to work little better. So uveitis and secondary glaucoma because of that is a major cause of visual morbidity. Early detection and adequate management of IOP is crucial. Identifying the mechanism of glaucoma, addressing the underlying cause of uveitis improves the long-term outcome of the patient. Monitoring the disc and field and watching for progression is very essential. Collaboration between the uvea, glaucoma, and also the immunology part of it is quite essential, and it is a challenging disease to treat, not for the doctor alone, it is also challenging for the patient. So patient education is very important. Thank you for your patient listening.
Thank you, Dr. Jayasree, for an excellent overview of management of glaucoma in uveitis. I have a few questions for you. What is your experience with ripasudil in uveitis? I have found at least 2 patients in whom the glaucoma specialist started ripasudil and the patient developed limbus to limbus corneal edema in children. And that corneal edema actually took a long time to subside. It was very difficult to explain to the patients that it is not because of the uveitis itself.
The issue with the ripasudil is that ripasudil tend to produce this epithelial edema, that honeycomb edema in some subset of patients, and more so when they have a compromised endothelium. So that is a known entity, and it tends to go off by itself once you remove the ripasudil. That is a known entity, especially when the corneal endothelium is compromised.
There is no way we can know which patient will develop it.
There is no way.
Is there any increased propensity in children?
Actually, ripasudil and all, we are not regularly starting for children.
It was started as the last line, but because just before going in for surgery, patient was already on all the other medications. But I found this, and then it kind of worsened the situation quite a bit.
And in uveitis, already it is a red eye, and ripasudil and all those things, we have to tell the patient that it is going to be a very like tomato ketchup type of redness can be expected type of counseling needs to be given to the patient. But this honeycomb epithelial edema reverts.
Okay. So probably better to do it as last resort. Then second question is, when you're doing PI in angle closure in uveitis, most of the time the inflammation is not controlled. So is it okay? What is your experience with the inflammation? Does it go up after the PI?
So in pupillary block, there is no other option other than doing a PI. So whatever be the level of inflammation, if it is like very severe, this type of pupillary block, if the patient is not in ciliary shutdown phase, will be very symptomatic. So we have to do it. Because then only it will relieve the symptom of the patient, and hence we do, and we give a significant cover of topical, and if indicated, we have to give a systemic cover also.
So there is no contraindication. You have to go ahead and do the PI, isn't it?
And otherwise, with a high IOP, the optic nerve also gets the backlash.
So you also said that most of the surgeries that is preferred is the valved implant. But in my experience, a lot of my glaucoma surgeons are doing the RD implant. So is there a major difference between the two, or is it okay to go ahead with the non-valved?
The thing is, like hypotony is a major issue. This inflamed eyes, uveitic eyes, the risk of hypotony is a major problem. We have mechanisms to control hypertony, but there is no mechanism to control hypotony. So that way, a valve is always preferred.
Okay. Are there any questions from the audience?
Yeah, can I?
Yes.
Yeah. Is there time for a question? Yeah. Here.
Yeah, I think.
Okay, Natasha. Yeah.
We have 15 minutes, so there is time. I can't see where you're speaking from. There you are. Yeah, tell me.
I'm not a very tall person.
Treatment of glaucoma to cyclitic crisis.
yeah, can I complete my question?
No, there is a question from there, sir. First, let's take that first.
So I just want the opinion of the chair regarding glaucoma in uveitis. It's a very difficult proposition, you know. So we have been brought up saying that from the postgraduate times that travoprost or any of the PG analogs cannot be used in uveitis, in the setting of uveitis. But the evidence is not great, honestly. That is one thing. Second is, as a person who have been using, when you have people who are on travoprost or something, during cataract surgery, we stop that and then switch over to some other drug, less of anti-inflammatory thing. And then once you complete the cataract, you go back to travoprost. That was the thing. But what we have realized is that it doesn't really make much of a difference. So is it really, I mean, is travoprost or latanoprost really so much cause inflammation? Because the evidence, what they say is, I think, if you based on a very few case reports.
I think Dr. Jayashree has already said that. I'll give the mic to her.
So nowadays, we don't stop prostaglandin for cataract procedures. And if at all, I mean, the risk for CME as such with the topical...
No, I'm not asking about cataract. I just cited it as an example. Okay. I'm asking in uveitis, see, because you have very less options. Either you go for systemic this Diamox, or you have to go this napazidil and netrazidil. They are not free from complications either. So we have limited options, and you need a drug which causes 30-35% reduction in intraocular pressure.
So you can give prostaglandin analogs if the uveitis is not active, if it is not because of viral etiology. And you have to warn the patient about the risk of activation of uveitis. So if the patient comes with symptoms, you have to warn the patients that there is a chance of uveitis to come back. And ask the patient to come back if the patient gets back the symptoms. That is the only thing. Just warn the patient, but you can start, sir.
Practically, in our experience, prostaglandin analogs do not create. If the uveitis is fairly on its way to getting controlled, then PG analogs don't really add to the inflammation. Yeah, that is one thing I wanted to bring,
because the literature is,
Practically, in our practice, I don't think any of us face that problem. We always add it once the glaucoma is not getting controlled with the first line CA inhibitor and beta blocker. Next, we add prostaglandin analog usually. And even cystoid macular edema, at least in my patients, I have not seen after prostaglandin analogs.
Okay, thank you.
Somebody else had a question. Yes, sir.
Treatment of glaucomatous cyclitic crisis, Prosner-Schlossman syndrome.
Sir, usually the patient will be very symptomatic. Patient usually presents, and it will be like multiple episodes. When the episodes happen, the patient comes, you immediately start the steroids. It responds within no time. And as the inflammation subsides, the IOP also subsides. As the IOP is increasing, immediately you start the medications, anti-glaucoma medications. That the high IOP needs systemic assistance also. So when you start the medications, it immediately comes down. There will be a few more episodes like that. Because now what we are saying is that there is a viral etiology to it. So if the patient is getting recurrent attacks, then you are advising, I mean, you have to advise the patient to undergo PCR also.
Aquastap, and you may need antivirals for at least 6 months to stop the recurrences.
I have seen a patient 17 years old, 17 years, first attack. So he has 60 millimeter Hg of IOP, treated with Diamox for 7 days, and he asymptomatic for 4 years. Then he again came to 1 week back with same pressure. Okay. I see the previous prescription, intraocular pressure is 60 millimeter, and other eye 18. Okay. And we have given the Diamox and Brivex, glucomol and brinzolamide something.
I think if you have a 4-year gap...
But I have not given the steroid. Previously I have not used the steroid, so I don't give the steroid. after seeing the patient, I have seen the literature. So steroid I am not given.
Okay.
So I think steroid should be added, na?
You should add, because
should
it
add.
is trabeculitis
But,
that is
because of the
causing
high pressure, I get scared that steroid will also increase the pressure.
No, in this particular condition, you can safely add steroid because it will help in control of the trabeculitis and it will help in control of the IOP, but you don't need like a long-term tapering
steroid,
like we do in other
Yes, 1 to 2
conditions.
weeks of steroid.
Yes.
Okay, thank you.
Thank you.
It is the inflammation of the trabecular meshwork that has led to the increase in the IOP. So without that inflammation subsiding, the IOP is not going to come down. So you need to target that also.
Okay.
So anti-inflammatory is required.
Some other question?
Yeah, thank you, ma'am, for nice talk. I just wish to ask if you are injecting patient with intravital triamcinolone acetonide, so do you advocate giving empirical anti-glaucoma medications at same time, or if we find him later a steroid responder, then only to add?
We don't give anything empirically. We have to look for steroid response and then only give. There are no family history and all we can ask, but then you cannot predict for sure, no?
Okay.
But generally, we are all moving away from intravitreal triamcinolone.
I think two things are very important here. Like if a patient is a steroid responder, you need to plan your treatment very differently. If it is a non-infectious uveitis, I'll give you a classic example of a HLA-B27 associated uveitis, who is a known steroid responder. These are the patient you need to shift early to the immunosuppressive, because you need to bring down the chances of recurrences and inflammation significantly. Number two, any patients of uveitis, if you are not sure, patient has suddenly come to you, you don't have a proper follow-up to know or understand that whether the patient is a steroid responder or not, don't give anything which you cannot take back, like giving suddenly a tricot injection, and decision to give a suddenly intravitreal injections can be dangerous for the patient. You should not invite another trouble for the patient. Trying to treat the intraocular inflammation, if you are giving some intravitreal injection and you lead to again secondary glaucoma, so that's not going to help. So I think these are the points you should remember always treating a case of uveitis.
Yes, sir. Thank you, sir. So one more question to all the panelists about quantiferon TB gold test. So how it is added up in your evaluation of uveitic patients?
I think Mudit already answered it very nicely.
Yes,
that any kind of laboratory test, we don't read the laboratory test. It gives you a supportive actually evidence so that you can help in your decision making. So the quantiferon test is same only. Just because patient is having quantiferon test positive doesn't mean that you need to give a ATT if there is no other associated signs or any other evidence. So like any other test, you have to take that.
If you're asking between Manto and quantiferon,
Yes, yes. What extra edge you get with that?
I have almost completely shifted to quantiferon, except in patient who absolutely cannot afford it.
Okay.
Because it gives you a more, like an objective value. It is either positive or negative. So your confusion in your 12 millimeter Manto, 15 millimeter Manto becomes to a large extent taken care of. At least that is one less thing to worry about, is my take on it.
I have a slight different opinion, because I always value Monto very high, because if you are dealing with a granulomatous anterior uveitis, if you do a Monto, if it comes positive, it's good for me that at least I have some suspicion. Even if it is negative, I know that in sarcoid patient it can be negative. So it can help either way, but I agree with Natasha that quantiferon you may do, but it's better if you can do both the tests, if the patient can afford.
Let's take one last question. I think our next session people are here already.
Ma'am, I have a question regarding the Posner-Schlossman syndrome only. So I had a patient who's a middle-aged male, and he had an episode of acute uveitis. And we all know that we have to start steroids, topical steroids, along with NSAID. To reduce the inflammation. I also started the same, but the IOP it still got increased, and in the next visit I recorded an IOP of 50 to 60 millimeters of mercury. So I started on Diamox for the same patient and to decrease the intraocular pressure, and within a week the pressure got reduced, but as soon as I tapered the steroids, I had started prednisolone first, and then I moved to dexamethasone. Because of the IOP spike, I thought he's a steroid responder.
Okay.
So my confusion is like in a patient of Posner-Schlossman.
Can you reduce the music, please? We are taking a question here.
So in a patient of Posner-Schlossman syndrome who might be a steroid responder, how like do we approach such patient to reduce the IOP and the steroids? How do we manage? Because for the I mean auto.
No, when we are talking about Posner-Schlossman as such,
Yeah,
the presentation will be with raised IOP with very minimal inflammation, because the inflammation is predominantly in the trabecular meshwork. You will not see it in the anterior chamber as cells. If you have a very symptomatic uveitis to start with cells in the anterior chamber, it is unlikely to be Posner-Schlossman. You are dealing with uveitic glaucoma. So that is the difference. So in Posner-Schlossman, predominantly you need your IOP control with secondary steroid help. In the other conditions, you will need predominantly steroid with IOP control. I think they want us to dance now. I'll take your question personally. Dr. Mudit, Dr. Partho for a picture. Thank you all for being here today, and thank you AIOS for this opportunity. And I'll wind up this session with that.